presenters are here. So we are starting the free paper session of Neuro Ophthalmology 1, and everyone I think knows the rule. It is a 6-minute presentation and you have to be on time. So may I call upon the first one, Dr. Hema VK. Is she here? Okay, you are here. So she would be presenting COVID-19 related cranial neuropathies, a case series during the second wave. I think you can start.
On 11th March 2020, the World Health Organization declared the novel coronavirus disease caused by SARS-CoV-2 as a pandemic. It produces symptoms ranging from asymptomatic disease to fatal acute respiratory distress syndrome or death, depending upon the comorbidities and state of the immune system. Aim of this case series is to document cranial nerve neuropathy in COVID patients and to analyze the possible pathogenesis and prognosis in these patients. This is a retrospective study of a case series of 10 patients who presented to a neuro-ophthalmology department at a tertiary eye care hospital from May 2021 to July 2021, that is during the second wave, and they were followed up for a period of 3 months. Inclusion criteria included patients with cranial nerve palsy who were recently diagnosed positive for COVID-19, and exclusion criteria was patients with cranial nerve palsy who were COVID negative. Demographic data showed most of the patients were between the age group of 30 to 60. Very few were below 30, that is 2 patients, and 2 patients were above 60 years. And most of the patients were males. Presenting complaints were mainly double vision, drooping of upper eyelid, or referred from other specialties. Cranial nerves involved can be categorized into 2 groups: isolated neuropathy, which included 6th nerve and 3rd nerve, and multiple cranial nerve neuropathies, which included 2, 3, 4, and 5 and 6th nerve. 3 out of our 10 patients had isolated cranial nerve palsies, 2 had 6th nerve and 1 had 3rd nerve. 7 out of our 10 patients had multiple cranial nerve palsies. 1 out of the 3 isolated cranial nerve palsies had systemic illness uncontrolled, that is diabetes, but had good vision on presentation. Multiple cranial nerve palsies all had either uncontrolled diabetes or hypertension or heart disease and had vision less than or equal to hand movements on presentation. Only 1 patient was treated as OPD basis. Rest of the 9 patients were admitted in hospital, and 2 out of the 6 patients were on intensive care unit. The MRI showed either sinus involvement in the form of invasive pansinusitis or maxillary sinusitis, orbital involvement showing orbital apex soft tissue thickening, or intracranial involvement showing cerebritis or cavernous sinus extension. Severity of the sinusitis in this patient ranged from mild to invasive fungal sinusitis. 5 were diagnosed as fungal etiology and on MRI, and only 1 patient was biopsy-proved mucormycosis. Other relevant findings included fundus of the 2 patients had central artery occlusion, and 2 had optic atrophy, and 1 had disc edema. We could only find the chest imaging of 2 patients, which was normal. The patient with cranial nerve palsies who had negative neuroimaging were either treated with conservatively, and patients who had invasive fungal sinusitis was referred to ENT specialist and undergone debridement. 3 patients with mononeuropathy had good prognosis with complete recovery. Out of the 7 multiple cranial palsy patients, 2 had intracranial involvement and they succumbed to death. Rest 4 had good prognosis, and the other 4 had either visual or movement deficits. This is the overall summary of the presentations. So we did a publication research, and we found that there was a case series of 6 patients with isolated cranial nerve palsies in COVID-19 patient. They postulated that the cause of the cranial nerve palsies in COVID-19 may be due to direct invasion of the endothelial cells by virus, or secondary infected leukocytes causing pro-inflammatory mediators, or either the acute virus illness causing hypertensive episodes or uncontrolled diabetes. MRI of these patients and orbit should be done, and they highlighted this, but they told that no neurological, no 6th nerve radiological findings were seen in the 6th nerve palsy patient. Presenting complaints were ophthalmoplegia or visual loss. Associated comorbidities in this group was diabetes mellitus, similar to our study. Mycological analysis revealed infection with a mucor or aspergillus, similar to our studies. And the MRI showed either sinonasal, orbital, or cerebral palsy involvement. The overall survival rate in that study was 63.89. In our study was 80%. So the pathogenesis may be uncontrolled systemic illness, secondary infections, or COVID virus. So we conclude that post-COVID patients can have either isolated or multiple cranial palsies. External ophthalmoplegia can be the presenting complaint in invasive sinusitis. Multiple cranial palsies have poor prognosis, and multiple cranial palsies patients are usually seen patients with comorbidities. Neuroimaging showing invasive sinusitis is in most patients with multiple cranial palsies. So the take-home message is we highlight that ophthalmologists should be also included in the cases of multiple cranial palsies, especially in COVID-19 patients, because that can highlight how we can predict the prognosis of these patients. Thank you.
In your study, simply COVID alone is a cause for cranial palsy?
No, sir.
No. So even if the patient would have not infected with COVID,
Yes, sir.
you would have got the palsies.
Yes, sir.
So it is not at all related to COVID.
Sir, but
Actually, it accidentally happened in post-COVID
yes,
zone.
sir. Yes, sir.
So it is not at all related, right?
Yes, sir.
Okay, that's what I want to know. Thank you.
Let's start question. In those cases, how many were COVID antibody positive in the series?
Sir, all were COVID antibody positive.
Okay.
Have you tested the COVID antibodies?
Yes, sir.
You tested.
Yes, sir.
And have you noted the duration between the cranial palsy and the occurrence of the COVID?
So the
second wave?
patients who had
Is there any relation between?
patients who were COVID positive within 1 month of the presentations, we had included only that patients.
Okay, they were coming to you within 1 month of having the COVID.
Yes, sir.
Okay.
Thank you.
Okay,
We'll go for
thank
second
you.
paper.
Thank you, sir.
Now the second presenter, Dr. Sabyasachi Bandyopadhyay. Is he here? So now we are calling the third presenter, Dr. Vidhi Ankalesheria. She is presenting posterior reverse encephalopathy syndrome with myriad of etiologies and presentations, a case series.
Good morning. My name is Dr. Vidhi Ankalesheria from GSS Hospital, Mysore, and the topic for my presentation is posterior reverse encephalopathy syndrome, a myriad of etiologies and presentations, a case series. There are no financial disclosures. PRESS refers to a group of disorders that can present clinically with headache, visual changes, seizures, altered mental status, focal neurological signs in the background of high blood pressure with vasogenic edema or neuroimaging. This is a report of 4 cases referred to the Department of Ophthalmology due to marked diminution of vision at presentation. All patients underwent visual acuity testing, anterior segment evaluation, dilated fundoscopy, magnetic resonance imaging, and refraction for BCVA at follow-up. Patients were admitted, investigated, and managed systemically according to underlying etiology. The case 1 is a 42-year-old male, hypertensive with retroviral disease, presenting with sudden diminution of vision in both eyes since an hour, with the BP of 190-110 millimeters of mercury, and the visual acuity of PL plus with inaccurate PR. Anterior segment showed horizontal jerky nystagmus in all cases. MRI showed subcortical T2 flare hyperintensities in bilateral parieto-occipital pons and bilateral cerebellum. This is the image. The yellow arrows show the hyperintensities in the parieto-occipital lobe. Treatment was oral antihypertensive. Visual acuity at day 1 was counting fingers at 2 meters, which improved to counting fingers at 6 meters on day 2. BCVA at 1 week was 6.9. The diagnosis was typical PRESS due to immune reconstitution syndrome. Case 2 is that of a 32-year-old male with incidental concentric LVH, sudden complete loss of vision in both eyes since the day associated with headache and vomiting, with a BP of 230 by 110 millimeters of mercury. Visual acuity in right eye was PL plus with an inaccurate PR in superior quadrant. Left eye had accurate PR. Anterior segment was within normal limits with grade 3 hypertensive retinopathy in both eyes. MRI showed symmetric T2 and flare hyperintensities in bilateral parieto-occipital and cerebellar hemispheres. This is the image showing the hyperintensities. Treatment was injectable followed by oral antihypertensives and prophylactic oral levetiracetam. Visual acuity at day 1 was counting fingers at 6 meters, and at day 2 it improved to 6.12. BCVA at 1 week was 6.6. Diagnosis was typical PRESS due to hypertensive emergency. The third case is that of a 35-year-old male, type 2 diabetic on insulin with pulmonary TB on anti-tubercular therapy, presenting with gross diminution of vision progressing over a day, associated with dizziness and an episode of loss of consciousness for 10 minutes. The visual acuity was PL plus with accurate PR in both eyes. MRI showed symmetrical areas of altered signal intensity in cortical and subcortical regions of bilateral parieto-occipital lobes and right frontal lobe. Acute lacunar infarct was seen in the frontal lobe on the right side. This is the image showing the hyperintensities in the cortical and subcortical areas. The treatment was intubation for low Glasgow coma scale and ATT was continued. Visual acuity at day 1 was counting fingers at 2 meters and day 10 it was 612. The diagnosis for this case was atypical press. Case 4 is that of a 25-year-old female, gravida to abortion 1 at 29 weeks of gestation with morbid obesity, presenting with convulsions, vomiting and sudden diminution of vision in both eyes. Visual acuity with hand movements at close to face. MRI showed multiple areas of altered signal intensity in bilateral parieto-occipital white matter, left coronary areata, bilateral thalami and pons. Treatment was emergency cesarean section. BCVA at 1 week was 6 baths. The diagnosis was typical press due to imminent eclampsia. Press can have varied pathophysiologic theories causing it. Vascular theory states hypertension causing overwhelmed autoregulatory mechanisms, leakage of blood vessels causing vasogenic edema. The second one is endothelial theory causing systemic inflammation leading to endothelial dysfunction. The last one is the ischemic theory which states that there's vasospasm leading to ischemia. We have reported 4 cases with 3 males and 1 female. 3 cases were of typical press and 1 was that of atypical press. On MRI T2 weighted and flare images, there was most common appearance of hyperintensities of cortical matter in parieto-occipital lobes according to Fugate J.E. et al. Cases with similar radiological findings in the frontal lobe, cerebellum, basal ganglia are seen atypically as stated by Ahn K.J. et al. And Covarrubias D.J. et al. Patients with autoimmune disease are more likely to have cerebellar involvement, whereas those with sepsis or active infection are more likely to have cortical involvement, as noted by Fugate J.E. et al. The same was concluded from our study. The first image is that of hyperintensities restricted diffusion on flares seen in the cerebellar area, as noted in the case 1 with autoimmune disease. And the second one is showing more cortical and subcortical involvement in infective etiology, that is the case of tuberculosis. Visual symptoms due to press mostly improve within a period of days. Roth C. Ferbert et al. Estimated the average time for recovery about 3 to 8 days. Recovery in our case was 7 to 10 days. There are reports of cases with protracted course of visual symptom recovery, but they are comparatively rare. Concluding, this cluster of cases establishes the need for high suspicion index in certain clinical presentations, such as sudden loss, marked diminution of vision in both eyes, associated with high BP, systemic inflammatory conditions or vascular pathologies. Although appalling at presentation, reversion of vision to normal within a period of 7 to 10 days and improvement of clinical condition suggests excellent prognosis in cases of press. These are my references. Thank you.
So you have not done visual fields when the recovery was there in any of the patient?
Sir, at presentation, the visual acuity was really
at
low.
presentation it was not possible because you are telling PR or PL. I'm
Yes.
asking at the time of when recovery was there. So have you noted?
Sir, in 1 or 2 cases, we were able to visual fields on confrontation, but some patients were not there for follow-up for visual fields. They were not willing for it.
It is written now at 1 week 6 vision was there.
Yes, sir.
So at that time you did the your visual
It
field.
was done for 1 patient, but not for all, sir.
So that is significant. That should be there. And the 4th patient, you have not shown how much blood pressure was raised. You have not even written in that.
So
That was a patient of eclampsia, pre-eclampsia,
Yes,
and emergency cesarean was done.
yes, sir.
So you have not noted down the blood pressure.
So when the case was referred to us, the blood pressure was within normal.
So they were followed up for only 7 days or for further few weeks to
So
note down whether their blood pressure was coming down and it was whether they were on antihypertensive for long or the antihypertensive was stopped when the visual acuity recovered or the blood pressure recovered to normal.
So for 3 patients, the blood pressure was high. After eclampsia, 1 recovered. The other 2 were on antihypertensive only till that period. 1 of them continued antihypertensive treatment, 1 did not, sir, because he was not like an
And
essential
was there any
hypertensive.
neurological deficit in the patient in which that cerebellum, pons and intensities were there?
No, sir.
There was no neurological deficit.
No, sir. objective is that, ma'am, we must have high suspicion index for press in these presentations, and how it can have good visual improvement, so that because we are managing the cases at presentation and we have that suspicion, as soon as we control the underlying pathology, we can get back the visual acuity as soon as possible, and there's no long-term deficit.
Because what madam is trying to ask, because press is a diagnosis of exclusion.
Right.
You know that, no?
Yes, sir.
So there should be a message for the masses, okay, this is how we concluded and this should be there, that you should do this if the
So
patient
in-
is coming like this.
I mean to say that in these cases, we should have high suspicion index and go for MRI and get a diagnosis of press as soon as possible.
Because patient is coming with PL or PR inaccurate, young patient, definitely their relatives and the patient would be definitely apprehensive,
Yes.
and you have to assure them
Yes,
within 7 days or 10 days, at least you can get your vision back.
Right, sir.
Okay, thank you.
Thank you.
Now the next presenter is Dr. Meenal Soni. Dr. Meenal Soni. When the 2 minutes are remaining for your presentation, you get a just buzzer from, so you need not have to worry about that buzzer. I think you can start.
Yes, sir. A very good morning to one and all. I have no financial disclosures. So to begin with, we all know what mayhem the COVID-19 pandemic has caused, especially the second wave, during which the death tolls touched new peaks every day. As if this was not enough, we saw a tremendous increase in a rare opportunistic disease, which added to the mortality and morbidity of these patients. So these are the few cases that presented at our hospital, and they belong to all walks of life, and they presented with a myriad of signs and symptoms. What else we found was the facial nerve palsy, which has been documented as a neurological manifestation associated with COVID-19. The frequency of which reported from 11 to 40%. Its etiology has been proposed to be caused by microthrombi formation, direct viral damage, or an autoimmune reaction towards the nerve. So other than direct inflammation by the pathogen itself in the orbit, facial nerve palsy also causes significant ocular complications in these patients. So we decided to conduct a study with the following objectives in mind. Firstly, we're reporting the frequency of facial nerve palsy in post-COVID ROCM patients in all its different forms and associated ocular complications, proposing the etiopathogenesis for it, emphasizing the importance of early diagnosis and intervention, and also clinical site localization of facial nerve palsy and its correlation, the correlation of clinical localization with radiological findings. It was a prospective cohort study conducted for a period of 3 months at a tertiary care hospital. Inclusion criteria was the patients of facial nerve palsy diagnosed clinically with proven post-COVID ROCM by microscopy or histopathology or culture. A thorough clinical history, ocular examination, and cranial nerve examination was done. Facial nerve examination, both motor and sensory, to find the clinical localization, and ocular complications were identified, corneal involvement graded, based on which the patients were treated either with a lubricating agent, lid patching, or tarsorrhaphy. MRI brain orbit PNS, both plane and contrast, was studied to find the involvement along the facial nerve course and to correlate it with the clinical localization. So this is how the clinical localization of the lesions was done into various levels, 1 to 6. We graded the corneal involvement based on this corneal involvement grading given by Ezra DG et al. In 2008, from 1st to 6th, ranging from punctate epithelial erosions to microbial keratitis. So these are the few pictures showing macroepithelial defects, microbial keratitis, stromal whitening with epithelial defect, descemetocele formation, and corneal melting with pseudocornea formation. What we found was from a total of the 300 patients examined, we found 10% patients, 30 patients of facial nerve palsy with a male-female ratio of 2.3:1 and a median age of 45 years. All patients were lower motor neuron type and associated with some form of ocular complications in the ipsilateral eye. corneal involvement up to grade 2 in 16 patients was found, and grade 3 and above in 14 patients. So the point to be noted is that most common site of localization clinically was the site 5, which is distal to chorda tympani, and radiologically was infratemporal fossa. We also found 6 cases of incomplete facial nerve palsy with the site of involvement distal to branching of the motor trunk. These are few patients of complete type of lower motor neuron palsy, and these are the MRI pictures showing inflammatory lesions in infratemporal fossa. These are the patients of incomplete facial palsy. We found 3 patients with involvement of frontalis, orbicularis, and elevators with sparing of the depressors and platysma. This is the case that we found in which the frontalis and elevators and frontalis and depressors were spared with the involvement of orbicularis and elevator, which was confused as a case of upper motor neuron palsy initially. We also found isolated orbicularis involvement, which is a rare entity, and we proposed post-COVID mucormycosis as a differential for this entity apart from leprosy and idiopathic causes. So the clinical localization of the facial nerve palsy in post-COVID mucor patients significantly correlated with the radiological findings with a p-value of 0.0127. All patients were under observation and have been followed for a minimum of 2 months, in which the facial nerve palsy neither evolved nor regressed, and the corneal condition improved in all these patients after medical management and tarsorrhaphy. So I conclude that facial nerve palsy is a common cranial neuropathy in post-COVID ROCM patients, and it does cause severe complications. Lower motor neuron type was the most common with various different presentations, and to incomplete and complete type of facial palsy, the commonest site of insult radiologically was in the infratemporal fossa, and it had a good clinico-radiological correspondence. The isolated lesions along peripheral nerve course presenting as incomplete facial palsy. So recognition of these patients is important to manage ocular complications. Thank you.
So apart from therapy for cornea, what antifungal drug you used or they used?
Yes, sir. Sir, we were using IV amphotericin B for the patients admitted, and those on follow-up were given tablet posaconazole.
Okay. Any surgery done for ROCM?
So those who had subsequent involvement of the sinuses had undergone FES surgery, and for ocular involvement, we did give retrobulbar amphotericin injections, and those who were requiring exenteration, they were, yes, sir.
Okay. Orbital involvement was also there?
Sir, I didn't get you.
Intraorbital involvement of mucormycosis
Yes,
was
sir. Yes, sir.
It was there.
Intraorbital involvement was also there.
So any proptosis you noticed?
Yes, sir. A lot of patients also had proptosis and extraocular muscle paralysis due to involvement of the third and sixth nerves.
Okay.
Third, fourth, sixth nerves, yes, sir.
Okay. Thank you.
Thank you, sir.
So it was not an isolated facial nerve palsy. It was
Sir, we found 2 cases of isolated orbicularis involvement.
Okay, thank you. Now the next presenter is Dr. Hirika Gosala. She's here.
Comparison of the glaucomatous from the non-glaucomatous optic neuropathy using optical coherence tomography. Glaucomatous optic neuropathy is one of the most common optic neuropathies described with its optic nerve head changes and the visual field defects. Non-concomitous optic neuropathy comprises ischemic optic neuropathy, optic neuritis, and compressive optic neuropathy. Differentiating non-glaucomatous from glaucomatous optic neuropathy is difficult due to its different natural history, treatment, systemic association, and vision impairment. Compressive optic neuropathy diagnosis is critical because it can be life-threatening, and only 21% of ophthalmologists could diagnose compressive optic neuropathy by looking at the fundus photographs. The cup size assessment is challenging in most cases due to the arbitrary reference plane distinguishing the rim from the cup. Elevated intraocular pressure is a risk factor for glaucomatous but not useful for differentiating between glaucomatous and non-glaucomatous optic neuropathy. The newly diagnosed glaucomatous optic neuropathy had an intraocular pressure of less than 22 millimeters in 50% of US and Japanese population, and hence there's a need to develop an objective measurement to aid in differentiating glaucomatous from non-glaucomatous optic neuropathy. The recent description of the measurement of the minimum rim width at the Brooks membrane opening is said to provide an objective measurement of cupping. The aim of my study was to differentiate glaucomatous with non-glaucomatous optic neuropathy using the same method. An ethics committee approval was taken. 20 patients of glaucomatous and 20 of non-glaucomatous optic neuropathy were considered. Informed written consent was taken. Inclusion criteria was pale optic disc, intraocular pressure less than 21 millimeters of mercury, and open angles. Exclusion criteria was secondary glaucoma, age less than 18 years of age, media opacities, clinical evidence of diabetic retinopathy and macular degeneration, and patients unwilling to undergo MRI scans. A complete ophthalmic examination was done, including best corrected visual acuity, optic nerve head photo, color vision, intraocular pressure and visual field effects, and optical coherence tomography measuring minimum rim width Brooks membrane opening. So the OCT protocol for the same minimum rim width Brooks membrane opening was radial scans of 24 equally distributed high resolution 15-degree scans were taken on the optic nerve head, which were further segmented into 6 sectors. Namely, temporal, nasal, superotemporal, inferotemporal, superonasal, and inferonasal. The minimum rim width was then measured of the Brooks membrane opening manually by a single operator and corrected if any error. MRI scans and CT scans of patients were taken for patients with compressive optic neuropathy, and we found 2 patients of meningiomas and 1 patient of cavernous sinus lesion, and they were sent for urgent referral to the neurosurgeon for further management. Twenty glaucomatous and 20 non-glaucomatous optic neuropathy patients were included in my study. The gender distribution for glaucomatous optic neuropathy was 10 males and 10 females, and for non-glaucomatous optic neuropathy was 10 females and 7 males. Age distribution was for glaucomatous optic neuropathy was 69.45 and 58.5 for non-glaucomatous optic neuropathy. The mean of the Brooks membrane opening for the minimum rim width showed lower values for the glaucomatous optic neuropathy compared to the non-glaucomatous optic neuropathy in all sectors, as you can see in the statistics. The study demonstrates that minimum rim width Brooks membrane opening provides a good objective differentiation between the 2 groups in tightly phenotypic clinic-based population of glaucomatous and non-glaucomatous optic neuropathy. OCT is a routine investigation in most high-resource centers for assessment of glaucoma patients, and hence this can be included as a routine investigation through the OCT platform. The possibility of non-glaucomatous optic neuropathy could alert the clinician for prompt treatment and need for other investigations like MRI scan, color vision, reassessing the visual fields, or re-examination of the disc to consider evaluation of pallor rather than cupping. These results only help in differentiating glaucomatous from non-glaucomatous, but do not provide any aid in subtyping the specific non-glaucomatous, which have been already presented. Larger study samples for less common non-glaucomatous optic neuropathy and compressive optic neuropathy may help to identify characteristic OCT findings that may assist in differentiating each of these conditions from glaucoma, which is a big challenge otherwise. This study has highlighted a practical meaning besides the presenting aspects for the pathogenesis of glaucomatous optic neuropathy. It may lead to rediscuss whether the patients with ophthalmological diagnosis of normal pressure glaucoma need neurological examination and the need of objective assessment of optic cupping with the aid of minimum rim with Brooks membrane opening measurements in OCT to differentiate glaucomatous from non-glaucomatous optic neuropathy. These were my references. Thank you. No, I wouldn't. But mainly where there are patients with ambiguous presentation of pallor and cupping, wherein the physician or maybe your expert is not seeing it and you are confused if the pallor is more or the cupping is more, we can use it as an assessment. This is not conclusive, but as an assessment to see if it's going towards glaucomatous. Yeah, we are doing perimetry for all patients.
Meningioma. What was the perimetry finding in those patients?
Ma'am, actually, we have seen that a lot of compressive optic neuropathy patients have a perimetry very similar to glaucomatous optic neuropathy patients because of the compressive lesion. So we have seen there are papers that have said that perimetries cannot be conclusive of patients, especially of compressive optic neuropathy. So hence they are saying that you should go forward with MRI scans for the same, and also not everybody can afford an MRI, so maybe we can include a OCT before referring the patient for
And did you come across any patients where your OCT was positive and you sent the patient for neuroimaging but it turned out to be normal?
Yes, ma'am, there have been patients
So
which we have been...
So then that's an expensive affair, right?
Yes, ma'am.
So I think we should
ruling
concentrate more on basics rather than OCT, because like you said, OCT is still an expensive machine, and in the general population, like a medical, I mean, like for a small setup, you may still
Ma'am,
not
but,
have an OCT. So you're saying that every patient where you're in doubt, you would want an OCT?
Only in scenarios where there's a benefit of doubt, because these patients, if they have a compressive lesion, it can be very life-threatening. And there have been patients being treated for glaucoma only to realize later.
Compressive lesions would definitely show some changes on the perimetry.
Yes, ma'am, but...
So I think this is just an extra investigation.
Yes, ma'am, it's an extra investigation. It's not conclusive. We can include is what we are trying to say.
We have shown 3 patients which were positive on MRI. Okay,
yes,
2 patients were having meningioma and 1 was having cavernous sinus lesion. So what was the other finding in the 17 patients of non-glaucomatous
so there were 9
neuropathy?
patients of ischemic optic neuropathy with pallor. Then there were 3 of atoxic, then 2 or 3 of traumatic optic neuropathy. There were other non-glaucomatous optic
Because you have not shown in the results, na, what
we have I've shown in the pie chart, I think.
Okay, you have shown in the pie chart.
Yes.
Because your mean age was 58 in the non-glaucomatous. And you are saying ischemia was there. So mainly ischemia is, though patient, they are hypertensive and more towards the advanced
the
age.
higher
That means,
age, yes, sir. But the 2 patients that we had of compressive and toxic were a little younger age. So.
Okay, thank you.
Thank you.
Dr. Avni Chandram is there.
My presentation is ocular myasthenia, a retrospective study in a tertiary center in South India. No financial disclosure for this study. Introduction. Myasthenia gravis is a treatable autoimmune disorder. Types are ocular, bulbar and generalized. Females are more affected in generalized MG and males are more affected in ocular MG. Males are affected in 60 to 70 years and females are more affected more than 30 years. Pathophysiology. Antibodies mediated damage and destruction of acetylcholine receptors in the neuromuscular junction of skeletal muscle impairs neuromuscular conduction and causes weakness and fatigability of skeletal muscles. Ocular myasthenia gravis affects extraocular muscles, levator muscles and orbicularis oculi. Most common presentation is ptosis, unilateral or bilateral with diurnal variation. 90% of ocular myasthenia progress to generalized myasthenia. Materials and methodology. Type of study. A retrospective observational study. Study population is all patients presented with drooping of one or both eyelid with diurnal variation to Neuro Ophthalmology department. Study duration is from January to April 2021. Study details. All patients presented with unilateral or bilateral ptosis. underwent clinical examination with fatigability test, ISPAC test, cocaine slit twitch, repetitive nerve stimulation test, serum acetylcholine receptor antibody test, and a trial of pyridostigmine was given. Observation and result: age distribution ranges from 43 to 76 years with mean age of 56. Gender: males are more affected in the ratio of 2:1. Duration: symptom duration was ranging from 1 to 10 months. Laterality: 14 were bilateral and 16 were unilateral. Symptoms: all patients presented with unilateral or bilateral ptosis with diurnal variation associated with diplopia in 6 patients, and systemic symptoms were present in 4 patients. 3 were dysphagia and 1 were dyspnea. Fatigability and ISPAC test was positive in 26 patients and RNS was positive in 24 patients. Acetylcholine receptor antibody was positive in 12 patients. Out of 12 patients with antibody positivity, 9 progressed to generalized MG and 3 lost follow-up. Treatment: 22 patients responded well to treatment with pyridostigmine and 8 lost follow-up. Discussion: age distribution in our study, mean age is 56. Some et al. And noticed the mean age as 40 years, and Nair et al. Noticed in males it affects between 60 to 70 years and females in 30 years. Sex distribution: Nair et al. Noticed that males are affected in ocular MG and generalized MG females are more affected. Symptoms: ptosis with diurnal variation was most common symptom in our study. Nair et al. Also noticed the same. Investigation: fatigability test can be performed in any small setup. It gives an insight and helps to proceed with further confirmatory tests. 87% of our patients showed fatigability positive. It can be elicited by watching for development of ptosis on sustained upgaze for 1 to 2 minutes. ISPAC test was positive in 87% patients. It is safer, cheaper and reliable test which can be done in normal clinical setup. Almeida et al. Noticed that it is more sensitive and specific than hydrophonium test. In patients with RNS normal and serum acetylcholine receptor antibody negative cases, it is more useful. It can be done by keeping ISPAC wrapped in a towel over closed eyelid for 2 minutes and measuring the palpable fissure height before and after. Improvement of ptosis more than 2 mm is significant. ISPAC positive cases are shown. Electrodiagnostic test, RNS test. According to AAO, 75% of patients with generalized MG and 50% of ocular MG showed RNS positivity. Our study, 80% got RNS positivity. Katzberg et al. Concluded that low RNS sensitivity is there even in severe cases of ocular MG. This is a case of right eye RNS positivity. Serum acetylcholine receptor antibody test. In our patients, 40% showed antibody positivity, out of which 75% turned to have generalized myasthenia and 3 lost follow. Peeler et al. Noticed that older age male sex and progression to generalized MG is associated with positive antibody. Treatment: 73 patients responded well to treatment with pyridostigmine, acetylcholine and esterase inhibitor. Treatment aims mainly medical and aims to improve muscle weakness and to achieve remission. Conclusion: it is of paramount importance to diagnose ocular MG and start on treatment promptly for symptomatic relief and prevent the progression. Patients presenting with variable ptosis always think of myasthenia gravis. ISPAC test is very highly sensitive and specific test and can be done in any clinical setup. Patients with acetylcholine receptor antibody positivity has a high chance of progression to generalized MG. Limitations: interpersonal variability can occur while interpreting the test results. Long-term follow-up needed for proper comparison of the progression. These are my references. Thank you.
Any of the patients needed thymectomy for thymoma? Surgical treatment.
So generalized myasthenia was out of 30 ocular myasthenia, 12 were having generalized myasthenia, after which 3 patients had diagnosed to be thymoma by the neurologist.
So how do you diagnose a thymoma?
Ma'am,
How do you diagnose the
CT
thymus?
thorax.
So you've done CT thorax as part of your.
Neurologist did. We didn't add it in our study.
What is the objective of this presentation? I mean, you've just shown us a few
Data,
cases of
yes.
myasthenia.
Mm.
Clinical manifestations are not unusual. They're very textbook. Everybody knows about myasthenia. So what are you trying to prove with this paper?
Ma'am, ocular myasthenia, almost 80% may progress to generalized myasthenia.
That is also well documented in literature. So what is the purpose of this presentation?
ISPAC 2.
It is also
there, yeah.
documented. So when you're presenting a free paper, there has to be some objective, no? That means in these number of myasthenia patients that you saw, what was the commonest presentation? How much time did they take to respond to treatment? Was any steroids added?
No, ma'am. We didn't add.
But all
steroids.
myasthenia
Neurologist-
patients they will not respond alone to.
No, you treated those
pyrodostignity.
patients or you referred the patient to neurologist?
Neurologist only treated.
That means you did not treat the patient. You
We
just diagnosed with this ISPEC test and referred the patient to neurologist.
We did RNS also and
RNS you did. You were
Okay.
having at your lab. And
yes, RNS is
in the
there.
in the ophthalmology department, it was there.
It was there, sir.
Sir, we will plan. Conference with Bombay.
So the next presenter is Dr. Karthik Kumar Mani. Is here.
Good afternoon. My presentation is on retrospective study on multiple cranial nerve palsies, pre-COVID versus post-COVID. Ocular motor cranial nerve palsies are caused by microvascular ischemia, trauma, inflammation, infection, infiltration, tumor, or aneurysm, of which ischemic etiology is the most common cause of isolated nerve palsy. Benign microvascular disease rarely causes simultaneous involvement of more than one oculomotor cranial nerve. If signs and symptoms indicate more than one nerve involvement, complete neurological evaluation and appropriate neuroimaging needs to be done. Proper workup of these patients and prompt diagnosis is essential since they may be vision threatening and life threatening, which needs timely intervention. So we intend to study the etiology and clinical profile of multiple cranial nerve palsies in a tertiary eye care center in South India and compare between pre-COVID and post-COVID period. It was a retrospective observational study. Data of 92 consecutive patients presenting with multiple cranial nerve palsies in the Neuro Ophthalmology Department of Aravind Eye Hospital, Coimbatore, over a period of 18 months between September 19 and March 21 were collected from hospital record. Multiple cranial nerve palsy was defined as involvement of two or more non-homologous nerves. Patients with neuromuscular junction disorders, myopathies, brainstem syndromes were excluded. Visual acuity, color vision, central fields by Jerem screen, anterior segment and fundus examination were done for all patients. Higher functions, cranial nerves, cerebellar function were assessed. Presenting complaints and systemic history were recorded. Appropriate blood investigations were done. Neuroimaging was done in all patients. Data were analyzed and compared using SPSS software version 21. Total of 92 patients, in which 16 patients were in the pre-COVID period between September 19 and February 20, 76 patients in post-COVID period between March 20 and March 21. Mean age of presentation was 48 plus or minus 15 years, and median duration of presentation was 14 days. Among the cranial nerves, 6th and 3rd cranial nerves were the more commonly involved, with 6th nerve at 72% and 3rd nerve at 70%, followed by 2nd and 4th cranial nerve at 47%, 5th cranial nerve 34%, and 7th cranial nerve 25%. 27% of the patients had diabetes, 18.5% of the patients had hypertension. Males were more commonly affected than females in the ratio of 3:1. Right and left eye were equally affected. The common presenting complaints were defective vision and double vision, followed by ptosis, headache, and eye pain. Etiology, inflammatory cause was the most common with 38%, followed by trauma at 32%, infection at 13, and tumor 11%. Comparing with pre-COVID and post-COVID period, inflammatory cause was the most common in both the groups, whereas infective cause was more common in post-COVID period and traumatic cause was more common in pre-COVID period comparatively. So cranial nerve palsy refers to disorders that lead to partial or complete loss of cranial nerve functionality. We found that the most common etiologies were inflammatory followed by trauma, infective and tumor. Inflammatory cause was most common etiology in both the groups. Infective etiology was found to be more in post-COVID group, and traumatic cause was found to be less in post-COVID group when compared with the pre-COVID group. One possible explanation is that COVID infection predisposed the patients to secondary infections such as invasive fungal sinusitis and mucormycosis. Traumatic cause was found to be less in post-COVID group, probably due to reduced road traffic accidents because of lockdown restrictions. Diabetes, hypertension, and hypercholesterolemia were the most frequently associated systemic histories. KIAN study is the largest reported retrospective series of 979 patients over 34-year period. Tumor was the most common cause, with schwannoma being the commonest. In Menon et al. Study, which included 54 patients over 2-year period, infective cause was the most common, followed by neoplasm. Fungal and tuberculous etiologies were equally common. Sixth nerve was commonly affected among all nerve combinations. In our study, third and sixth nerves were found to be the commonly involved. Inflammatory etiology and trauma were common in our study. In Dalival et al. Study, they found that closed head injury with ocular motor nerve palsy was more severe than those without ocular motor nerve involvement. Third cranial nerve palsy was associated with relatively severe head trauma. We had 29 patients with traumatic etiology in our study. 34.5% had third nerve and 41% had optic nerve involvement. Men were more commonly affected. This was a trend seen in other studies with ratios ranging from 1.2 to 2.5. 47% of the patients had optic nerve involvement. 41 out of 92 patients had vision less than 6/60 in the affected eye. In the infective etiology, one patient had cerebritis with cavernous sinus thrombosis, and one patient had invasive fungal sinusitis with intracranial abscess. Among the vascular etiology, one patient had giant saccular aneurysm, and 3 had CCF. Tumor, schwannoma was the most common. Other tumors were cerebellar medulloblastoma, metastasis, nasopharyngeal carcinoma, clival chordoma, and lymphoma. In conclusion, we found that the most common causes of multiple cranial nerve palsies were inflammatory, trauma, infective, and tumor. Infective etiology was found to be more in post-COVID period when compared to pre-COVID period. Clinical examination of all cranial nerves is essential, and neuroimaging plays an important role in finding out the exact etiology and prompt treatment. Fungal etiology and neoplasm should be ruled out since they are vision and life-threatening, which needs timely intervention. Limitations of our study include its retrospective nature, coupled with limited number of patients and restricted time period of 6 months in pre-COVID period. These were my references.
How many patients got bilateral cranial nerve palsy? So is it only right eye or left eye you mentioned? How many patients you got bilateral, both sides? How many patients you noticed?
Sir,
Bilateral means
laterality, sir.
Yeah, he's asking about laterality. How many were having bilateral?
See, you mentioned right eye and the left eye are equally involved. How many patients you noticed in both sides?
Sir,
Cranial palsies?
sir, actually
No.
it was, no,
No,
sir.
that's also more important.
Yeah, you have not
In
shown.
tumors, see, in cavernous sinus thrombosis, both sides will be involved. In tumors, both sides will be involved. You have not mentioned that.
And you have not mentioned which cranial nerve was involved in pre-COVID area more commonly and which were in post-COVID area. That is how you can conclude that there is a difference. And because I think etiology-wise, pre and post-COVID were almost same.
Yes, sir. Yes, sir.
And you have noted that trauma, because in post-COVID or in the COVID era, the trauma was less common because people were not coming outside.
Yes.
But in still, you have shown that the trauma almost the same in the pre-COVID and the COVID or post-COVID era. Because you have, I think your post-COVID era, that post-COVID era start from March 2021.
20, sir.
Till or
Okay.
Sir,
the post-COVID era, or it was the COVID and post-COVID era both?
sir,
The time period.
Sir, pre-COVID we had only 6 months, sir. We have taken.
No, you have
data.
noted down that 2019, September 2019 to March 2020.
Yes.
After that, it was COVID and post-COVID also.
Sir, 1 year we have taken, sir.
Okay. Thank you. So the next presenter is Dr. Rakshita Kene.
Good afternoon all. I'm presenting neuro-ophthalmic sequelae in COVID recovered cases during the second wave of pandemic. The severe acute respiratory virus identified in the Wuhan city of China has caused several multisystemic manifestations, including the neurological and neuro-ophthalmological complications. It has exhibited its neuro-ophthalmic manifestation not just due to mucormycosis, but also due to its neurotropic nature. So the usual symptoms of COVID were flu-like symptoms and the gastrointestinal symptoms. Eventually, we came to know about the ophthalmological manifestations of COVID involving almost every layer of the eyeball. So the spike protein, which is a characteristic feature of SARS, is thought to be interacting with angiotensin converting enzyme receptors present on every cell of the human body, including the brain cells and nerve cells. The neuro invasion was thought due to the dissemination of virus either through the olfactory bulb and the cribriform plate or the hematogenous spread. Aim of this study was to study the neuro-ophthalmic manifestations after the highly lethal second wave of COVID. So this is a prospective study. We recruited 37 cases with history of COVID infection in the month of June and July. Inclusion criteria were history of COVID symptom, RT-PCR positive cases, negative cases with symptoms. Exclusion criteria, cases of retinal pathologies such as CRVO, and we took a detailed history of patient, COVID positive status was noted, and then duration since positive status, systemic history, treatment history, and history of hospital admission was noted. Out of 37 cases, 19 were male, 18 were females. The median age was 45 years, and 6 out of 37 cases were diabetic. So out of total, majority of cases presented with headache, 4 with papillary edema, 3 with third cranial nerve palsy. The rest, 1 was fourth cranial nerve palsy, 1 was sixth nerve palsy, 2 multiple cranial nerve palsies, 3 with transient visual loss, 2 perioptic neuritis with infective etiology, 2 orbital apex syndrome, 1 third nerve palsy with fungal sinusitis, 2 asthenopia, 1 papillitis, and 1 non-arthritic anterior-ischemic neuropathy. 19 patients were home quarantined, 32 patients were tested RT-PCR positive, 18 patients were hospitalized, 6 received steroids, and 8 were vaccinated. 2 were vaccinated before the manifestation. Median duration was 42 days. So discussion, previous reports on neuro-ophthalmic manifestations have shown cranial neuropathies, visual loss due to Miller-Fisher, myasthenia gravis, papillary edema, optic neuritis, and visual loss due to posterior reversible encephalopathy syndrome. In our study, there is no correlation of immunocompromised state to the neuro-ophthalmic manifestations. There are no pre-COVID vaccination status has also no effect on the manifestation, and majority of the cases manifested after 1 month, so there is no evidence of direct invasion of virus. We also reported a subclinical case of COVID presenting as papillary edema, diagnosed as post-COVID related inflammatory meningitis by the neurologist. SARS-CoV-2 is told to cause inflammation, endothelial injury, and vascular injury, which leads on to prothrombotic state, and thus leads to venous and arterial thrombotic events, leading on to papillary edema, NAION, and transient ischemic attack. SARS-CoV-2 antigen also incites host immune response against endogenous MOG antibody, and MOG antibody crosses the broken blood-brain barrier, causing optic neuritis. We reported some cases after our study duration. Those were 6 CVA presenting as homonymous hemianopia, 3 cases of CVT presenting as papillary edema, 2 cases of myasthenia gravis, 2 ADS people, and 1 multiple sclerosis. SARS is caused to mimic the acetylcholine receptor, which triggers the autoimmune response, the immune response, which causes post-infectious myasthenia gravis. Neurotropism of SARS also causes denervation of postganglionic supply to iris sphincter, thus causing ADS people. Post-COVID vaccination cases were also noted, 1 case of multiple sclerosis and 2 non-arthritic anterior-ischemic neuropathy. So there is a temporal association between vaccination and multiple sclerosis. Vaccine triggers the immune response and accelerates the transition from subclinical to clinical case. Immune-mediated pathogenic mechanism was observed in vaccine-associated NAION. So the presence of adjuvants and the extracellular RNA in COVID-19 vaccine can promote the coagulation and thrombus formation. So conclusion, though cases of COVID have decreased in number nowadays, new strains of COVID still continue to evolve. Many neurological diseases with dreadful sequelae presents as neuroophthalmic symptoms. So one should be vigilant while dealing with neuroophthalmic cases, and frontline physicians should also recognize these signs and screen for them while treating the patients. These are my references. Thank you.
Any questions?
Any difference you noted between a COVID case and the normal, all this manifestation, long-term treatment or any other biologics or other things in non-infectious cases?
No, sir. We have not followed for that.
No, how many cases you have taken for your study?
37 cases in the
How
duration.
many were COVID negative?
COVID negative, actually, sir, many cases were 18 were positive, so rest were negative.
Around more than 10
But they
were
had
negative.
the symptoms, COVID symptoms. So
Okay.
we have.
Then how will you
included those.
correlate whether it is due to COVID or not COVID? It is not at all related.
Yeah,
I-
it's a
we
diagnosis
should
of
say
exclusion.
It's just
definitely.
coincidental.
Yes.
Whether patient had COVID infection or not, that should have happened. Because of general disease or injury or any other inflammation. What do you say, madam? I don't think it's due to COVID or post-COVID.
Because they were COVID negative and you have noted
Yeah,
that.
same number you got.
So, but we have even got one antibody positive patient was negative for COVID.
Did you
Did you do that COVID antibody test in all the
yes,
patients?
No, not in all the patients. She was a case
Because
of papilledema and she was diagnosed
That
by
is how only you can say the subclinical cases, because you have written subclinical.
Yeah.
I should say post-COVID patients won't get this neuropathy because they would have got some steroids.
So not all.
Because of COVID, they would have got some steroids and neuropathy would have lessened in post-COVID patients. Because the study shows like that. Okay, thank you.
Thank you.
Next is Dr. Shamila.
So I will be presenting a retrospective study on etiology and clinical profile of optic neuritis in South India. Optic neuritis is an inflammatory disease of optic nerve characterized by sudden loss of vision and pain on extraocular movements. Optic neuritis is further classified into typical and atypical forms. Typical causes include it can be present as isolated demyelination or it can be a part of multiple sclerosis. Atypical causes include neuromyelitis optica spectrum disorder, chronic relapsing inflammatory optic neuropathy, autoimmune infection, autoimmune optic neuropathy, infection, and post-vaccination. There are certain novel biomarkers associated with optic neuritis, which include aquaporin 4 IgG or anti-NMO antibody, which is against the water channels of the astrocytes, which comes under neuromyelitis optica spectrum disorder, and also myelin oligodendrocyte glycoprotein immunoglobulin, MOG IgG, which target the myelin and oligodendrocyte, that is myelin associated oligodendrocyte associated disorder. MOG IgG can also be detected in proportion of anti-NMO antibody negative patients. And what is the aim of our study? It was to determine the etiology, clinical profile, and treatment outcomes of optic neuritis patient. It was a retrospective study. We collected data from Jan 2020 to June 2021 from our electronic medical records department. All patients were subjected to complete ophthalmic examination, routine laboratory work like complete blood clone, blood glucose, and chest X-ray. Neuroimaging was done for all patients. Anti-NMO and anti-MOG antibody and autoimmune profiling were done for patients who presented with recurrent or bilateral lesions or whose MRI showed demyelination. We treated all the patients with IV methylprednisolone according to ONTT trial, except for those patients whose MRIs showed features of demyelination or if the antibody test was positive. These patients received IV methylprednisolone 1 gram for 5 days, and long-term immunosuppressive treatment was initiated by the neurologist after tapering oral prednisolone slowly. We included all patients who presented with features of optic neuritis, aged 18 to 70 years. We excluded the patients lower than 18 years and 70 years, and we also excluded the glaucoma and retinal disease patient. Other causes of optic neuritis such as compression, trauma, and ischemia, patient with incomplete medical data were also excluded. These are the results we got. 124 eyes of 101 optic neuritis patients were included in the study. Mean age of presentation was 36, and 39% were male, 60% were female. Papillitis was more common than retrobulbar neuritis. 3 patients had multiple sclerosis. 4 were positive for anti-NMO, and 7 patients were positive for anti-MOG antibody. 5 patients were negative for both anti-MOG and anti-NMO antibodies. 78% had unilateral presentation and 23 had bilateral presentation. Recurrence was more common in retrobulbar neuritis patient. 45% had visual acuity of 20/200 or more during presentation. All the patients who tested positive for anti-NMO antibody and anti-MOG antibody had visual acuity of 660 or lesser. The patient who tested positive for anti-MOG antibody had a better visual outcome than anti-NMO antibody. Coming to the discussion, mean age of presentation in our study was 36 and was female preponderance, which is in concurrence with other similar studies. Bilateral involvement was seen in 23 patients in our study. 52% had papillitis, unlike in ONTT, where it was only 35%. A study by Rohit Saxena et al. Reported 53.5% of papillitis, hence papillitis is equally common as retrobulbar neuritis in Asian population. Recurrence was seen in 17%, which was more common in retrobulbar neuritis patient, which is also in concurrence with Rohit Saxena et al. 3 patients had multiple sclerosis in contrast to ONTT. Of that 101 patient, 4 patients were positive for anti-NMO. In a study by Pandit et al., 3 out of 59 optic neuritis patients had NMO. In our study, 7 patients tested positive for antibodies. In a similar study by Or Petabiti et al., 20 out of 95% patients tested for anti-MOG antibodies. Limitations, short follow-up period, and only those patients who presented with bilateral recurrent lesion and whose MRI showed features of demyelination were subjected for anti-MOG, anti-NMO antibody assay. We conclude that all patients with optic neuritis presenting in atypical fashion should be suspected for atypical causes such as anti-MOG antibody disease or MOG-associated disorder. Even though some of the patients may be seronegative for anti-NMO and anti-MOG antibodies, MRI may be helpful to identify these atypical causes of optic neuritis. Hence, imaging must be done in all cases of optic neuritis, which may be helpful in identifying these lesions early and aid in early medical interventions. Since most of the agents used in multiple sclerosis are ineffective in treating NMO and MOG-associated disorder, we should consider these antibody testing, incorporate their testing in diagnosing optic neuritis. These are my references. Thank you.
You mentioned MRI, so do you do plain MRI or with something?
If we suspect demyelination or something, we do contrast, ma'am. It's decided by radiologists.
All patients of optic neuritis, you have to do an MRI with a contrast. You can't do a plain MRI.
Yes, ma'am.
You've mentioned only MRI, but you've not mentioned MRI with contrast. That is the gold standard investigation for any patient where suspecting an optic neuritis. What are the demyelinating signs of optic neuritis on the MRI?
Ma'am, in case of multiple sclerosis, we can see the short segment involvement demyelination. And in case of NMO spectrum,
classical sign?
Periventricular plaques we can see, ma'am.
So if you have a patient whose MRI has signs of demyelination, will you still want to investigate for the antibodies?
No, ma'am. After MRI only we decided for anti-MOG antibody and anti-NMO antibody.
Those were negative or positive, then you subjected them to antibodies? The negative cases or the positive cases?
MRI,
yeah.
Sir, MRI if we suspect long segment involvements as in which is typical of NMOSD and MOG-associated disorder, if the MRI shows pictures of NMOSD, we are sending for
because in atypical cases you have to subject the patient for the spine also, na?
Yes, sir.
So straight away you have just subjected the patient for MRI brain and spine, or they were MRI brain?
Sir, MRI spinal cord also they have
in each and every patient?
No, sir. If we suspect demyelination disorder, sir. Radiologist.
Because
suppose if the MRI is negative and antibody seronegative.
Yes, sir.
What treatment do you suggest?
Sir, even if the MRI is negative, sir, if the patient is having bilateral involvement, again we are giving the IV methylprednisolone for 5 days and slow tapering of steroids in contrast to ONTT trials, sir. If
Yeah, if it is due to non-specific papillitis or retrobulbar neuritis in unilaterally,
unilaterally we are
you
following.
Did you try any retrobulbar steroids?
No, sir, we didn't try any
No, I
retro.
don't. In those days, when MRI was
Yeah.
not available, we used to give retrobulbar steroids.
Yeah, decadurabolin and the dexamethasone. at that
Either
time.
retrobulbar hydrocortisone or retrobulbar dexamethasone for 1 week.
Only one thing is there, your data showed five cases which are NMO and the MOG antibody negative. Now whether what investigation, additional investigation we have done in those 5 cases?
Sir, we have done all the preliminary workup which includes complete blood down ESR and serum blood glucose and chest X-ray to rule out infectious etiology, sir. Then in case of recurrent and bilateral, those patients who can afford only, we subjected all the patients for those patients. We can ask we have asked the patient to go for anti-NMO, sir. Due to financial constraints, all the patients with bilaterality we couldn't get NMO anti-NMO testing.
Only concern is that apart from infection, the collagen disease for the rheumatoid arthritis can cause a atypical optic neuritis. Okay, all this situation we have to
Like an
arthritic condition.
AION.
Yeah.
Okay, thank you.
Thank you, ma'am.
The next one is Dr. Jayagopal Agarwal.
Wasting time to start high dose.
Respected chairpersons, my paper is wasting time to start the high dose of IV methylprednisolone for aquaporin 4 or MOG positive optic neuritis is a blunder for visual recovery and outcomes, as we have no financial interest. According to the North American Optic Neuritis Treatment Trial, as published in the New England Journal of Medicine in 1992 in February, the acute treatment of optic neuritis in multiple sclerosis by IV methylprednisolone accelerates the recovery but does not affect the final visual outcome. Thus, it leads to sense of non-urgency in the treatment in acute phase of optic neuritis. But the clinical course of optic neuritis with the new era of biomarker, such as aquaporin 4 and MOG positive patients, differs from multiple sclerosis, typically steroid responsive, very much steroid dependent, associated with poor visual outcome and recurrence, and poor recovery from each attack increase the accumulative disability. The purpose of this study is of the optic nerve. We will try to find out the role of high dose of methylprednisolone and whether the earliest treatment, that is showing the urgency, results in the best corrected visual acuity recovery after 3 months. First, we go for the diagnosis of the optic neuritis based on the clinical history, objective finding as determined by the clinical examination of neuro-ophthalmologist and the paramedical test. After sorting out the inclusion criteria and exclusion criteria, we have diagnosed case, all the diagnosed case of optic neuritis had to have the diagnosis of aquaporin 4 and MOG positive associated with optic neuritis, based on the established diagnostic criteria, international consensus of diagnostic criteria of NMOSD in 2015. For practical consideration, we have some for aquaporin 4 and MOG test. We have considered only those optic neuritis which has unless classical MS or atypical optic neuritis with severe vision loss. Besides that, there are other criteria also. I'm not going in detail, but the aquaporin 4 and MOG positive antibody are tested cell-based assays. It is a retrospective study. On total number of cases 38, and on which the 30 cases are aquaporin 4 positive and the MOG is 8 cases. All records are taken from the neuro-ophthalmology department and neurology department between the 2016 and 2021. This study focused on the visual acuity as a functional outcome, not the other functional parameters such as visual field, a structural anatomical outcome measurement as OCT. Documentation done for the age of the patient, sex, antibody groups, and the time to start the IV methylprednisolone in days, BCV at the start of at the time of the first reporting, and 1 month and the 3 months. The treatment is given even if the antibody status is not known. The IV methylprednisolone daily dose of 1000 milligram for 3 to 5 days, followed by the order prednisone 1 milligram per kg body weight per day for 11 days. Then taper off the next 21 days. It can be prolonged in cases of relapse or in cases of where there is aquaporin 4 or MOG positive antibody is only evident in the clinical and paraclinical findings. Now, calculation done for the BCVA 1 month, 3 months, and it is again grouped into those for achieving the 6-6 vision and those worse than 6-6 vision. Interquartile ranges over 1 month and 6 months. Outcome are correlated with the times that from the symptoms onset of to IV methylprednisolone. ROC curve was analyzed for sensitivity or specificity. Jordan's index are for the best cutoff time, and we also calculate the relative risk, odds ratio, and confidence interval. Now, the main outcome is the 3 months BCVA, and secondary outcome, the failure to regain the 6-6 vision or 20/30 vision at the end of the 3 months. These are the data of my studies. For age-sex distribution, no doubt the female has more preponderance, and for the especially in the aquaporin 4. For the MOG positive, it is though female is male, our number is more, but any age, sex, and even the children are affected. The trend shows that the early treatment is a good result, but the trend is the same whether we whatever the start of the treatment is. Now we come to the distribution. Distribution of BCVA for the patient treatment with the methylprednisolone or for aquaporin 4 on MOG positive test. In both cases, the treatment within the 7 days are better than the patient treated after the 7 days. This is the analysis of the ROC curve. Here again shows the area under the curve is 0.8, and here in these cases, the Jordan's index for the best cutoff time for IV methylprednisolone achieved is 4 days. Sensitivity and specificity 81 days. If we segregate with the age and BCVA, then individual area under the curve is less, and rather than if we add all the 3 predictors. So, the role of IV methylprednisolone is established. The same thing is if you analyze the analysis of failure to regain the 20/30 as a dependent variables. The inference is our study shows the patient with aquaporin 4 or MOG positive test, positive optic neuritis respond better with the earlier IV methylprednisolone. The odds ratio, when the odds ratio is high, then there is a less not good prognosis. So odds ratio is higher in the if it is more than 7 days, and if it is results is better for if it is.
Yes. What is there?
Yes, I have told that. But the point is what is the cutoff time? Yeah, it is, if it is
you need not wait for 1 week.
No, I have also.
You should have finished the treatment before all the results will come.
No, I have stated that before starting before we get the result, whether it is about the biomarker, we start the treatment at 1,000 milligram per day for the 3 or 5 days, and then we taper it to 1 milligram per kg per day for 11 days, and then it is tapered. And if it is, even then it is, if it is recurs after sedation, then we start again with the fresh one.
Now, why it is in some patient 3 or in some patient 5 days?
Yes.
You have written 3 or 5 days.
Yes.
So why it was not 3 days or it was not 5 days?
No, it is the Jordan's index, what is calculated from the Jordan index. That is 4 days. If it is early treatment, and it is very good result. Even if you start the treatment within 7 days, it is also good, but not too much as we odd ratio as shows in our statistics.
Dr. Agarwal, when you order a MOG or a aquaporin, it is not usually in the same city where maybe it is transported.
Yes.
Then what measure you take, because this is very important, particularly for this transport.
That's why I am telling that before starting, before getting the result of aquaporin 4 and or MOG positive test, we start the treatment at least. We start the treatment without wasting the time. This is the main theme of this presentation.
Any other question? Thank you. The next presenter, Dr. Harshvardhan is here. this is a keynote address from Dr. Harshvardhan. Yes, kindly proceed.
Yeah, good afternoon everyone. I'm Dr. Harshvardhan Ghorpade from DOVSI Institute, Fortis Hospital, Vashi, Navi Mumbai, along with my co-author Dr. Sunil Morekar. We have worked on this topic, artificial intelligence and Wolfram language in papilledema and its management. So these are the contributors, and there is no financial interest. Article in New England Journal of Medicine had suggested that artificial intelligence can be used to detect papilledema by looking at fundus photographs, by feeding the photographs in the machine. And this was done for neurologists who were not very comfortable using the fundoscope to diagnose papilledema. But our job is not just to diagnose, but also to confirm the presence, also to confirm visual disruption, also to find if there is progression of visual disruption, and finally also to find out if damage has set in, atrophy has set in, and it is irreversible. Visual disturbance has been known through this paper, where they have found that there is a significant correlation between visual field sensitivity loss and the grade of papilledema. And in this paper, it has been found that around 24% of people were found to have blindness or severe visual impairment who had papilledema. So visual loss is a huge issue. These are the various risk factors we all know, which were also used to feed in the machine, including male gender, hypertension, anemia, black race, younger age, obesity, high opening pressures, severe papilledema on presentation, and significant visual loss at presentation. So in short, timely advancement of treatment would occur if loss of neurons could be diagnosed at an earlier stage of evaluation, while the optic disc edema is still present. So early diagnosis is important, and early intervention is equally important. The purpose of this study was to compare the conventional artificial intelligence tools in papilledema versus Wolfram language analysis, which is a newer tool for predicting the outcomes. 291 cases of papilledema were studied and were analyzed by the conventional versus the Wolfram language, and multiple regression analysis was performed. These are the kind of pictures that were fed to the machine, including the pre-op and post-op images, 3D OCT scans, as well post 1 month as well. And further, optic nerve photographs were not only fed as photographs, but also in segmentation forms. So this is unclassified pictures and and this is when the vessel segmentation is done. Here we can find how the vessels disappear as the papilledema progresses, initially at the rim of the optic nerve and then from the center of the disc. This is another picture where the vessel close to the optic disc has been removed. Harrelix entropy is basically the level of commotion or disorder in the retinal nerve fibers, and these pictures can be fed and analyzed by the machine. More the papilledema, more the commotion. This is the Frisson grading of papilledema we all know, but the features that were introduced were not only the grading, the features as per the grading, but as per the blood vessel features like vessel discontinuity index, vessel discontinuity index to disc proximity, also peripapillary texture like energy of the peripapillary region, entropy of the peripapillary region, and also disc margin obscuration like obscuration around the disc margin obscuration in the nasal pole, temporal pole, etc. So the top 10 indices that were used for prognostication were these, like vessel discontinuity obscuration under disc margin, nasal to temporal ratio, vessel discontinuity index to disc proximity, etc. And Wolfram algorithm is a programming language which has made this prediction even more, has improved the prediction even more. It is a mathematical language. This is a website of Wolfram Mathematica from where the programming was used. And we basically selected cases or rejected cases on the basis of the classic algorithm versus the Wolfram, and the results were analyzed for success to test the algorithm. So it's an ongoing process. It was also compared with cases which were done in spite of the algorithm suggesting failure, and also compared with cases which were who refused surgery, although the algorithm was suggesting success. So all these results were put in the machine to make the machine even more give us better results in terms of artificial intelligence. Also pictures like these, like dynamic retina, were introduced, which talks about the flux of blood flow through the retina to the arterioles and veins, which also talks about pulsation of the veins as well as the arterioles and the optic nerve head. Fractal dimensions were also added, in which the entire photograph is divided into fractions, and each fraction is analyzed individually into a graph and graded from grade 0 to grade 5. The pre-op, post-op images, where the disc photographs showed improvement in the disc margins, as well as the Brooks membrane analysis in terms of Brooks membrane rupture were also fed. So in short, we found that when the algorithm, the conventional form was used, it showed 89% sensitivity and specificity of 82, while the Wolfram gave us 84 sensitivity and 89 specificity. But when used combined, it predicted the outcome in 90% of the cases. So accuracy of machine learning has already been mentioned in this paper from BMC Ophthalmology, where they used it for optic neuropathies and pseudopapilledema. So in short, in conclusion, if algorithm allows surgery, only then we should operate, while the combined algorithms give a better prediction in the outcomes. Thank you very much.
Thank you, Dr. Harshvardhan, for your nice presentation. Now I would call upon the last presenter, Dr. AIOC2022. Yeah, she's there.
Good afternoon. So I'm presenting a case series of 3 patients. So my talk is called Eye, the Brain Spy. So tuberculosis is known to present in the eye with myriad of manifestations, and depending on the location of the inflammation, the visual symptoms are observed. Tuberculous meningitis is primarily a disease of the brain and spinal cord and has a strong predilection for the basal parts of the brain. So we present a case series of 3 young patients between the ages of 15 to 25 who presented with varying degrees of visual loss and were diagnosed with tuberculous optochiasmatic arachnoiditis. Steroid therapy was initiated in all 3 of them as per the optic neuritis treatment trial. So our first patient was a 21-year-old male who was referred to the ophthalmology OPD with a history of sudden progressive loss of vision since 10 days, which was associated with a pain behind the eyes. There was a past history of chest infection 6 years back. The documents were suggestive of pleural effusion, and on pleural tapping, there was no conclusive diagnosis that could be reached. The patient was started recently on the antitubercular therapy empirically outside. Ethambutol was given for 21 days and discontinued due to visual complaints, as the doctors there outside were suspecting that it's probably due to ethambutol. But even on discontinuation and starting the patient on linezolid for 2 days, there was no improvement in the visual symptoms. Also, isoniazid was discontinued due to peripheral neuropathy before he presented to us. So at presentation, his visual acuity for distance was HMCF and hand movements in front of face, perception of light was present, and PR was accurate in the right eye. In left eye, it was 660, improving to 636. The extraocular muscles the movements were full, free, and mild pain in all gazes. The rest of the, as we can see, the rest of the lids and the conjunctiva, cornea, and corneal sensations, everything was intact. The pupil in the right eye showed a grade 1 RAPD. There was also a color vision abnormality noted. The near vision was less than N36 in the right eye, and in the left eye, it was N12. The posterior segment on fundus picture, it revealed no abnormality. The patient was advised further perimetry, which showed bitemporal field defects and a generalized field depression suggestive of a neurological cause. An MRI brain and a visual evoked potential was advised. The OCT was normal in both eyes, and the visual evoked potential was suggestive of slowed conduction along the bilateral optic pathways. The respiratory medicine simultaneously planned a bronchoalveolar lavage which was positive for tuberculosis, and an ATT was continued. Ethambutol and linezolid were discontinued as ocular symptoms are suspected secondary to the toxicity with ATT. Neuromedicine, the opinion was taken an MRI brain with optic nerve cuts, and CSF studies were planned as CNS TB was one of the differentials. MRI was suggestive of TB meningitis. Inflammation found was particularly around the optic chiasma, and a diagnosis of optochiasmatic arachnoiditis was made by the neurologist. Lumbar puncture was done, and CSF findings were suggestive of TB meningitis. A clinical diagnosis of retrobulbar optic neuritis secondary to optochiasmatic arachnoiditis was made, etiology being the CNS TB. ATT was continued, and the patient was also started on IV steroid methylprednisolone, which was given for 3 days, followed by oral steroid for 11 days to reduce the inflammation. In this particular patient, the visual acuity and color vision drastically improved to 6/6 to both eyes over a period of 10 days. Optochiasmatic arachnoiditis also improved with the steroid therapy, as was observed on repeat MRI. In the second case, the 18-year-old female was referred to the ophthalmology OPD with a history of sudden progressive loss of vision since 8 days. She was a diagnosed case of TB meningitis and had a history of ICU admission for the same. And she was already on antitubercular therapy. So at presentation, her visual acuity was also impaired in both the eyes, but the extraocular movements were painless. There was a grade 3 RABD present in the right eye, and the color vision could not be assessed as the near vision was less in both the eyes. Posterior segment picture again revealed no abnormality. Investigation showed an abnormal OCT with RNFL thinning, and MRI brain was done, which showed tubercles around the optochiasmatic area. The ATT was continued. The patient was started on IV steroid, again for 3 days, followed by oral steroid for 11 days as per the ONTT trial guidelines to reduce the inflammation. She showed no improvement and eventually progressed to no perception of light in both eyes over a period of 10 to 12 days. Case 3 was a 25-year-old female, again referred to us with a history of sudden progressive loss of vision since 7 days. She was again a diagnosed case of TB meningitis and was on ATT since 2 weeks. At presentation, again, her visual acuity for distance and near was impaired. There was a grade 1 RAPD in the pupil, in the right eye pupil. And we did an MRI brain, which again showed multiple tuberculomas around the optochiasmatic area. And IV MPS was started along with the treatment in conjunction with the physician and continued for 3 days. And then she was shifted to oral prednisolone. She improved to 624 in the right eye and 636 in the left eye over a period of 15 days, and no further improvement was observed beyond this. Mycobacterium tuberculosis can cause inflammation in any part of the eye, leading to corresponding visual deficits. It is therefore imperative to localize the site of inflammation so that the necessary treatment can be started. So, according to a study in the profile of optic neuropathies in TB cases, 5% of the cases are found to have retrobulbar neuritis. In a study published in Neurology India, 14% patients of TB meningitis showed optochiasmatic arachnoiditis, but the association with visual symptoms was rare. So in conclusion, ocular manifestations should be watched out for in all patients of both pulmonary and extrapulmonary TB. So in this particular paper, I want to highlight the part where we do an underlying checkup for all the patients who are diagnosed with respiratory TB and also with TB meningitis. Before starting the ATT, a baseline evaluation is done, but also the patient, once the treatment is started, it is often seen, it has been mentioned in certain papers, that once the treatment is started, there is a paradoxical worsening of the optochiasmatic arachnoiditis if it's a TB meningitis patient, and there are further visual symptoms observed. So a pre-ophthalmic workup and a regular ophthalmology follow-up when on ATT should be stressed upon, as ocular toxicity is seen with the in about 5 to 6% of TB patients in standard HRZD. And yeah, these are my references. Thank you.
Regarding anti-tuberculosis treatment, yes, you excluded ethambutol and INH, right?
Yes, sir. Yes.
So, how many in multi-drug therapy of ATT? How many drugs you have given for
Sir, there are...
Cerebral TB.
Sorry, sir?
Cerebral tuberculosis.
So, sir, there's an intensive treatment and a continuation phase. So, the first is the intensive treatment in which the 4 drugs are given, which are HRZD.
What are the drugs you preferred in those cases? In these 3 cases.
In these 3 cases, sir, actually we changed the ethambutol and the isoniazid and changed it to linezolid.
Okay.
But linezolid, since we had given it only for a very short duration in the first case, so we couldn't really see, because linezolid also has ophthalmic complications. But it was definitely observed that as soon as his treatment was initiated, his visual symptoms were observed in very close to that period. And according to certain papers, since these optochiasmatic arachnoiditis has not been mentioned much in ophthalmology papers, from what I saw, it has been mentioned more in neurology papers. So they mentioned that once you give the treatment, there is a paradoxical worsening in the visual symptoms and also of the symptoms in general of the TB meningitis. So it's best that you start the steroids early. There is always an unpredictable outcome, because most of the papers that I read, they said that they do not improve to 6/6. But in our case, the first patient, he improved to 6/6 and with a wonderful color vision improvement.
Thank you.
Thank you.
Now we conclude with this free paper session.